Hello there, and thanks for joining. My name's Simron Singh. I'm a professor of medicine at the University of Toronto and at the Susan Leslie Clinic for Neuroendocrine Cancers at the Sunnybrook Odette Cancer Centre in Toronto, Canada. The title of my talk today is First Line Therapy of Neuroendocrine Cancers, or NETs. So I'd like to start with a case that I think highlights some very important points about the first line therapy of neuroendocrine tumors, which generally encapsulates somatostatin analogs for the lower grade neuroendocrine tumors. So for this case, this was an actual patient of mine, a 76-year-old male who presented in September of 2019. Now, this was a gentleman who paid a lot of attention to his health and to his body and realized that something was wrong and sought out medical attention for this. He proceeded to a CT scan, which unfortunately showed an omental mass of approximately 5.5 centimeters, and he had bilobar liver metastases. The primary was thought to be in the terminal ileum. A liver biopsy was performed, which showed a well-differentiated neuroendocrine tumor with a Ki67 of 4%. This would mean he had a G2 well-differentiated neuroendocrine tumor with a suspected small bowel primary. Urinary 5-HIA, which is a reflection of serotonin production, was measured. Unfortunately, the urinary 5-HIA was above the upper limit of normal as per our lab values. However, it should be noted that this gentleman did not have the typical symptoms of carcinoid syndrome, such as flushing, diarrhea, or bronchospasm. A chromogranin A was also measured, which was approximately 10 times the upper limit of normal. At this point, we had to face that decision about what the next steps were to do. Watch and wait is still sometimes used in neuroendocrine tumors, and there was an opportunity to watch and reevaluate in 3 months. This patient could receive a somatostatin analog alone, surgery alone, combination of somatostatin analog and surgery. So is there any data that could guide us through this decision for this gentleman who was otherwise fairly healthy and presented what looked like a stage 4 metastatic low-grade 2 neuroendocrine tumor of the small bowel origin? Neuroendocrine tumors are somewhat poorly understood, and many times people think that these tumors do not need to be treated aggressively because they survive for a long period of time. We know that the outcomes of patients with neuroendocrine is quite heterogeneous. Known prognostic factors include location of the primary, the tumor stage, the extent of disease, the degree of differentiation or the tumor grade, the patient's age, and of course, the patient's performance status. And the graph here will show you that there are different outcomes depending on where the neuroendocrine tumor originates. What should be noted is that unfortunately, almost 2/3 of patients presented with advanced neuroendocrine tumors will not be alive in 5 years, thus indicating the need for aggressive therapy. When we look at this large SEER database that was done by Dr. James Yao and subsequently updated by Dr. Desari, with over 30,000 cases of neuroendocrine tumors, we showed that, in fact, those patients who have localized disease do have very prolonged survival times, somewhere along the lines of greater than 10 years. But those patients who have distant metastases or is stage 4, their median survival is 33 months based on this database. That's not much different than outcomes we would see, for example, in colon cancer. This gentleman certainly needed to be treated. The first thing we do was proceeded to surgery. This gentleman had a small bowel resection and mesenteric lymph nodes removed. Surgery at the primary, even in the face of metastatic disease, is often done and important to reduce complications down the road of mesenteric fibrosis, small intestine obstruction. And there is data to support that, in fact, removing the primary, even in the face of metastatic disease, can be beneficial for patients. This was a large retrospective series that looked at removal of the primary, which showed a survival advantage to removing the primary. And I will say there's been other series after this as well that have confirmed this. And it's generally thought that removing the primary can be helpful, although the data at this point is still not completely definitive. The pathology and the imaging at this time after the surgery revealed a well-differentiated neuroendocrine carcinoma of the ileum. The Ki67 as a pathology showed a Ki67 of 3%, still a G2 tumor. A terminal ileum mass was identified with a 1.7 centimeter in greatest diameter, and unfortunately, the CT scan subsequently confirmed multiple liver metastases. Patients who have some liver disease can often also be referred for tumor debulking. So after this operation, we now have a patient who has non-functioning NET with residual disease, feeling well with no symptoms, although he has extensive liver metastases. The urinary 5-HIA numbers, which I initially shared with you were elevated, had come down to normal after the surgery, even in the face of these liver metastases with the removal of his mesenteric bulk. So what do we do next? Do we observe this patient after he's had his primary removed, even though he has metastatic disease? Is there some sort of medical management that would be helpful for this gentleman? Somatostatin analogs remain the mainstay of treatment for the G1 and OG2 neuroendocrine tumors, especially of the GI origin. This originated from what's called the PROMID trial, which was published in the Journal of Clinical Oncology. This was a phase 3 randomized, double-blinded, placebo-controlled trial. It included patients with midgut nets alone, who were treatment naive, who were locally inoperable or metastatic. They had to have well-differentiated disease, and they could be functioning or non-functioning. They were then randomized to receive a standard dose of somatostatin analog, in this case, octreotide LAR, 30 milligrams every month, versus placebo. The endpoint of the trial, the primary endpoint of the trial, was time to tumor progression by blinded central review. What's interesting to note is here, upon entry, we don't know who had progressive disease or not, even though the endpoint of this trial was time to tumor progression. Secondary endpoints included objective response rate. This was the results of the trial, fairly significant, a hazard ratio of 0.34 or a 66% reduction in the risk of tumor progression. So clearly, octreotide LAR stopped tumor progression to a significant degree. What's interesting is when we look at the response rates, we don't see any complete responses or really any meaningful partial responses. The majority of benefit is seen in stable disease. And that's common with most somatostatin analogs. What we see is a cytostatic agent rather than a cytocidal. So when we talk to our patients about somatostatin analogs, we say we're trying to arrest the tumor growth rather than trying to shrink the tumor realistically. An interesting finding of the PROMID study was that in both patients who had functioning and non-functioning tumors, i.e., whether they were secreting hormone like our gentleman or not, as he was after the surgery, there seemed to be a benefit. There seemed to be an advantage to starting octreotide LAR, even if the patients were not, in fact, secreting hormone at the time. This, of course, was followed up by the much larger lanreotide study, which was called Clarinet, which was published in the New England Journal of Medicine. This study had a similar design, although it looked at patients who had a G1 or G2 gastroenteropancreatic neuroendocrine tumor, i.e., from anywhere in the GI origin versus just the midgut, and they could have a Ki-67 of 0 to 10%. The endpoint of the trial was progression-free survival, and I present to you here the primary endpoint results. As you can see here, the hazard ratio was 0.47, which resulted in a 53% reduction in the risk of tumor progression on those patients on lanreotide autogel. So this confirmed that somatostatin analogs in this patient population significantly prolongs progression-free survival. When we look at the subgroup analysis, these were exploratory analysis and not pre-planned analysis. But when we do look at the midgut and the pancreatic net, there seems to be an advantage for lanreotide autogel. You can see here on the pancreas side, although the hazard ratio crosses 1, there does seem to be clinical benefit. And this is probably a matter of it being underpowered. This was the first data we had that really showed that there seems to be a benefit across all GI neuroendocrine tumors for a somatostatin analog in first-line therapy. This effect was seen similarly over tumor grade. As I mentioned, the Ki-67 for inclusion of the study was 0 to 10%. So the 0 to 2% would be the grade 1s, and the 3 to 10% would be the grade 2s. And there appeared to be benefit for first-line somatostatin analogs, in this case lanreotide, in both the G1s and G2 tumors up to a Ki-67 of 10%. Above 10%, I'm going to talk to you about that shortly. So this gentleman was started, as per the Clarinet trial, on lanreotide, 120 milligrams every 28 days. He continues to do well, has no symptoms. He's an avid skier, and is spending time with his grandchildren skiing. He has CT scans every 6 months, and he's tolerating his treatment very well. We'll continue on this treatment and hope it provides him stable disease and a continued good outcome. So that really covers the GI neuroendocrine tumors up to a Ki-67 of 2%, or what I'll call low-grade 2s. What about those patients who present with a slightly higher grade or slightly more aggressive disease? Well, again, to illustrate that, I'm going to use a case study here. This case involved a 28-year-old male who presented to my office, very healthy, no past medical history, no family history of cancer at all. In fact, he was active and an avid athlete. His ECOG performance status was 0. Unfortunately, in June of 2020, this gentleman had a very sudden onset sharp abdominal pain. This did not go away on its own. So an urgent CT scan was performed, which unfortunately showed a 9.2 centimeter mass in the pancreatic head. This was well encapsulated and hypervascular, giving us a clue that this could be a neuroendocrine neoplasm. He did have some hemoperitoneum, likely due to minor bleeding from the tumor, which was quite large in size. Fortunately, his CT scan of his chest was clear, and there was no signs of distant metastases. A biopsy of the pancreatic mass was done in June of 2020. Now, I will say that this was done by EUS, and we have to take this with a word of caution because often we're only able to get cytology, which does make Ki-67 grading somewhat unreliable. Fortunately, due to some excellent work by our endoscopist, we were able to get a tissue biopsy in this situation, and the result was a well-differentiated pancreatic neuroendocrine tumor. It was high grade with a Ki-67 of 32.3%. Now, we generally divide the high-grade neuroendocrine tumors into a well-differentiated and poorly differentiated entity. And one of the ways we can do this, of course, is relying on our pathology colleagues to understand the cell morphology. In addition, however, when this is confusing or somewhat difficult to ascertain, we can look at RB and P53 and see if there's loss. Fortunately for this gentleman, the RB and P53 was intact, indicating this is likely a high-grade G3 well-differentiated neuroendocrine tumor. We were able to do a gallium dotatate scan, which confirmed that there was no signs of distant metastases, and the pancreatic mass was accreting 4, indicating an abundance of SSTR2 receptors. In July of 2020, this gentleman went for surgery. He had a Whipple procedure with a transverse colectomy with anastomosis. The pathology from the surgery revealed a well-differentiated pancreatic neuroendocrine tumor as suspected from the initial biopsy. The Ki-67 was fairly consistent at 36%. P53 and RB were maintained, fortunately, and there was negative resection margins with 0 out of 42 lymph nodes positive. Post-operatively, he did have a somewhat difficult course, unfortunately complicated by a leak from the GJ and infection. He required some prolonged IV antibiotics, including home IV antibiotics. After this, we did talk to this patient about adjuvant chemotherapy. There is no definitive evidence around adjuvant chemotherapy at this time, although currently trials are being done through the NCTN network. However, given the lack of any definitive clinical evidence for adjuvant chemotherapy, as well as his difficult postoperative course, this young man decided against adjuvant chemotherapy. Unfortunately, in January of 22, with routine CT scans, we showed diffuse liver disease, keeping with metastatic disease. A biopsy was done, which again revealed a well-differentiated pancreatic neuroendocrine tumor with a Ki-67 of 35%, fairly consistent with his original primary. A gallium scan was done, which showed a creatinine uptake of 3 to 4 in the liver metastases, again indicating the presence of SSTR receptors. We did an FDG PET scan, which is often done with high-grade neuroendocrine tumors to help understand the biology of the disease. The more uptake on the FDG PET, we understand that it's likely to be more biologically active. Unfortunately, there was only scant uptake on the FDG PET. The fact that there was a lot more uptake on the gallium scan indicates that this is generally better biology when it comes to the grade 3 well-differentiated neuroendocrine tumors. This gentleman was subsequently enrolled in a clinical trial that we were working on called the NETTER-2 clinical trial, and we'll discuss that with you now. This study was recently published in the Lancet with the primary results a few months ago, and the original results were presented at ASCO GI this year. So I have the pleasure of sharing you the results. The neuroendocrine trial looked at the efficacy and safety of lutetium dotatate in newly diagnosed patients with advanced G2 or G3 well-differentiated gastroenteropancreatic neuroendocrine tumors. This was a phase 3 randomized international clinical trial. So as I mentioned to you, neuroendocrine neoplasms are generally considered to divide up between well-differentiated and poorly differentiated. The well-differentiated neoplasms are called tumors, so well-differentiated NET, and the poorly differentiated neoplasms are called carcinomas, poorly differentiated neuroendocrine carcinoma. For the well-differentiated neuroendocrine tumors, traditionally we thought of them all to be grade 1 and grade 2, and all grade 3 tumors were classified as poorly differentiated neuroendocrine carcinomas. However, in recent years, we have a relatively new classification system that incorporates the clinical reality that there are patients such as this who have a well-differentiated grade 3 neuroendocrine tumor. Unfortunately, to date, before the NETTER-2 study, there was no prospective randomized studies that investigated the most appropriate first-line treatment strategy for high G2 or G3 well-differentiated gastroenteropancreatic neuroendocrine tumors. The NETTER-1 study preceded the NETTER-2 study and established PRT with lutetium dotatate as a treatment for progressive neuroendocrine tumors. The NETTER-1 study included patients who had midgut neuroendocrine tumors who had progressed on somatostatin analogs that were G1 or G2 disease only. The patients were randomized to receive lutetium dotatate with octreotide LAR or a standard treatment of octreotide LAR high dose. The results here are shown. The progression-free survival advantage for lutetium dotatate was 28.4 months versus 8.5 months for a hazard ratio of 0.21. The study was published in the New England Journal of Medicine and established lutetium dotatate as standard therapy for GI neuroendocrine tumors after progression on somatostatin analogs. The NETTER-2 study included a more aggressive population. In fact, the NETTER-2 study is the first randomized clinical trial to look at radioligand therapy, or PRT, as first-line treatment in any solid tumor at all in cancer. The inclusion criteria of the NETTER-2 study included patients who were 15 years of age or above, although all patients ended up being enrolled 18 years and above. 226 patients were randomized in a 2-to-1 fashion to receive 4 cycles of lutetium dotatate with octreotide LAR or a control arm of high-dose octreotide as per the NETTER-1 study. These patients had to have G2 or G3 gastroenteropancreatic neuroendocrine tumors with a Ki-67 of above 10% to 55%, so a more aggressive population. They had to have been diagnosed within the last 6 months prior to enrollment, have received no prior therapy, and really had no meaningful somatostatin therapy prior to enrollment. The primary endpoint was progression-free survival. Secondary endpoints included overall response rate and quality of life. Stratification factors included G2 versus G3, as well as pancreas versus other origin. The treatment was well tolerated. Fortunately, 88% of patients were able to receive all 4 cycles of lutetium dotatate. These are the progression-free survival primary endpoint results of the NETTER-2 study that was shared at ASCO GI this year. It showed that lutetium dotatate significantly improved progression-free survival in these patients. The median PFS on the lutetium dotatate arm was 22.8 months versus 8.5 months on the high-dose octreotide arm. The hazard ratio was 0.276, resulting in a significant 72% reduction in the risk of disease progression or death in the lutetium dotatate arm versus the high-dose octreotide arm. Fortunately, the PFS benefit was consistent against all pre-specified subgroup, including age, gender, race, tumor grade, tumor origin, as well as the degree of SSTR uptake. One of the exciting findings of the study was looking at the overall response rate. We did see some complete response, as well as 37.7% PR for an overall response rate of 43%. This is some of the highest response rates we see in neuroendocrine tumors to date. When we looked at quality of life, there was no difference between the 2 arms of the study, the lutetium dotatate and the octreotide LA arm study. There was neither an improvement nor a deterioration in quality of life between the 2 arms. Safety, of course, is always going to be a primary consideration when we are using treatment within the first line especially. As you can see here, the most common all-grade AEs included nausea, diarrhea, and abdominal pain. We saw slightly more nausea in the lutetium dotatate arm and slightly more diarrhea and abdominal pain in the high-dose octreotide arm. Most common grade 3 AEs on the lutetium dotatate arm included lymphocyte counts, increase of liver enzymes, as well as some cases of small intestine obstruction, which can occur with small bowel neuroendocrine tumors when treated with PRRT. There was slightly more abdominal pain in the high-dose octreotide arm. Of course, a key point of PRRT is secondary malignancies. At the time of report of this study, there was one case of MDS within the lutetium dotatate group, but I do caution that these are early results, and we will have to follow these closely to fully understand the extent of MDS. We did have the pleasure of being able to update these results at the ESMO GI Symposium to look at some of the subgroups to fully understand what role first-line PRRT dotatate could play in improving the care of our neuroendocrine patients. So when we were able to look at the subgroups in some more detail, fortunately, we were able to see that this benefit was consistent with grade 2 and grade 3 neuroendocrine tumors, as showed by the significant hazard ratio seen here. In addition, when we looked at the pancreatic and small intestine neuroendocrine tumors, again, we were able to see significant benefit in both subgroups. Looking at the overall response rate, we were happy to see that the overall response rate remained above 40% or elevated in the grade 2 as well as grade 3 NETs. And we were able to see that there was significant response rate in the pancreas subgroup. It was slightly lower in the small intestine subgroup, but this isn't surprising given the slower biological nature of the small intestine NETs as compared with pancreas. So, as going back to our case, this gentleman was randomized to the lutetium 177 arm on the NETTER-2 trial. He completed all 4 cycles of lutetium dotatate, and he had one dose delay due to thrombocytopenia, but otherwise tolerated the treatment very well with some mild fatigue. He had a partial response after receiving all 4 cycles and now remains on somatostatin analogs for maintenance. He continues to do well, and I saw him just last week, and he shared with me the excellent news that he and his fiancée are now engaged to be married. So with that, hopefully I've given you an overview of both the lower grade GI neuroendocrine tumors, in this case, a Ki-67 of 0 to 10%, and showed you some evidence for the use of somatostatin analogs, and also showed you newer evidence on the higher grade neuroendocrine tumors of GI origin from 10% and above, which showed potentially some benefit for PRRT in this patient group. Exciting times in neuroendocrine tumor treatment. Thank you.